after chronic inflammation, we are going to see wound healing, right? So next step what we are going to see is the wound healing. As we have discussed, chronic inflammation, there will be a mononuclear cell infiltration, then there will be tissue destruction, and then there will be repair or wound healing. So what we are going to study now, the next topic is wound healing. In wound healing, what we need to understand is consisting of three important steps, right? Consisting of three important steps. So number one, if there is a minor injury, they will completely heal, right? So that is called resolution. So when we are talking about wound healing in minor injuries, so there will be complete resolution. So here we can see three steps. Number one is the complete resolution. Complete resolution, which we will be seeing in minor injuries. So in minor injuries, there will be complete resolution. But in certain cases, you will see there is another aspect which is called as regeneration. What do you mean by regeneration? Regeneration means complete restoration of the lost tissue. So here we must understand what is regeneration. Complete restoration of the lost tissue. Complete restoration of the lost tissue. So complete restoration of the lost tissue. So complete restoration of the lost tissue, how? How they will be having complete restoration? That is the point we need to understand. Complete restoration of the lost tissue by what method? By proliferation of the parenchymal cells in adjacent areas, right? So by proliferating parenchymal cells in adjacent areas. So this will be complete restoration of the lost tissue by proliferating parenchymal cells, right? So by proliferating parenchymal cells in surrounding area, or you can say in adjacent areas. So that is the definition of regeneration. Means loss of tissue will not be there, or it will be completely restored because surrounding areas are proliferating, or surrounding areas parenchymal cells are proliferating, right? So on this basis, I would like to tell you a brief thing which usually DNB people or NEET people ask in exam. What kind of parenchymal cells we see in our human body? So here I would like to tell these parenchymal cells are of three categories. Just a brief introduction. There are three categories. What are these three categories of the parenchymal cells? It can be labile cells, right? This can be a labile cells, number one, or this can be a stable cell, or this can be a permanent cells. So that is what I wanted to tell you. There are three types of parenchymal cells which we will see in a human body, right? Labile, stable, and permanent. So now you can see these names are informative names, because labile cells will be continuously dividing throughout life. So they will be having continuous division. They will be having continuous division throughout life. So throughout life they will be dividing continuously. They are called as labile cells, right? Stable cells means what? Stable means they will be stable. When they will be given stimulus under some special circumstances, then only they will grow. So they are not dividing, but when stimulus will be given, they will divide. So usually they are non-dividing. Usually they are non-dividing cells, but under stimuli they will have growth, right, or proliferation. So usually they are non-dividing cells, but when they had been given a stimulus, they will be having growth. These are stable cell. Permanent cell, as you can see, the name itself is telling they are non-dividing cell permanently. So non-dividing only. So there is no division. Even if you give stimuli, they will not divide. They are called permanent cell. So now we will see what are the example of the labile cell. Example of the labile cell which will proliferate continuously is the bone marrow cell, right? Bone marrow cells or skin epithelial cells So bone marrow cell, skin epithelial cells, these are example of labile cells which will be proliferating continuously throughout the life. But non-dividing cells, under the stimulus, they will grow such kind of stable cell. This was the older question in all India exam. Stable cells. Stable cells examples are liver cells, and that was the answer in one of the all India exam. So in liver, in kidney, you will find stable cells, right? So these are stable cells, non-dividing. You give a stimulus, but they will not divide at all. These are the cardiac cells and neurons. So here example is the cardiac cells, right? So cardiac cells and neurons are non-dividing cells. So these are the parenchymal cells, right? So that is the point we have to keep in mind. The examiner may ask question like this. So this is about regeneration, right? Third aspect of wound healing is repair, right? Third aspect of wound healing is repair, right? So what do you mean by repair? Now question comes to our mind, okay, what do you mean by repair? Repair means in this case, lost tissue will be replaced by fibrocollagenous tissue, right? So repair means lost tissue, because some tissue will be lost, and how they will be restored. So lost tissue is replaced by, not restored, replaced by. Lost tissue is replaced by fibrocollagenous tissue, by fibrocollagenous tissue. So lost tissue is replaced by fibrocollagenous tissue. So question comes to our mind for the repair. What is repair consists of? So repair is little extensive topic which we are going to discuss now. Repair will be consisting of two events. So always remember, when we talk about wound healing by repair, so repair consists of two steps, right? So here we will see repair consists of two steps or two events, right? Number one is called formation of granulation tissue. So number one is formation of granulation tissue. Formation of granulation tissue. So this is the first step. And another thing is repair requires another step that is called as wound contraction. So these are two things we have to keep in mind. Okay, repair consists of formation of granulation tissue and wound contraction. So one by one we will discuss about these things, right? So before I start this discussion, formation of the granulation tissue, right? So now I am going to discuss about another important question which examiner had asked in this year AIMS exam and All India exam, DNB exam, all. Granulation tissue, right? So first we should know that granulation tissue should not be confused with the granuloma. Granuloma is a pattern of chronic inflammation, and granulation tissue is hallmark of wound healing. So that is the very, very important point we have to remember. What is granulation tissue? Granulation tissue is hallmark of wound healing, right? So hallmark of wound healing. So whenever we are seeing wound healing and examiner is asking what is hallmark of wound healing, you must remember hallmark of wound healing is the granulation tissue formation, right? So whenever wound will be healing properly, as you would have seen in your OPDs also, your surgeon will be asking you to open the dressing and see the color of wound, and when you will see, he will ask you pink or yellow. You will be telling, sir, it is pink. When he says pink, it's okay, fine. It means it's healing. Why it is pink? Because it is having granulation tissue. And why it is pink? Because granulation tissue will have proliferating blood vessel. So that is how significance of granulation tissue lies in wound healing. So whenever you will see pink wound, it means it's a healing because they are having multiple blood vessels. So before I talk about granulation tissue, I would like to discuss one important point, or you can say one important table which we should draw and understand. That is type of collagen. So this topic, I'm just going to tell you what are the types of collagens, because it is very essential to understand collagens. And one of the another important point which examiner had asked in All India DNB and NAMES exam this year, right? So first we should know that these names are mnemonic. Like for example, when you will see the bone, B O N E, see this name itself is a mnemonic. Bone is having type 1 collagen. So just remember, bone will be having type 1 collagen. Another important example is the cartilage. See this. Another example is cartilage. See, spelling has been distorted. Cartilage, right? Cartilage will be having type 2 collagen. So this is how we can remember cartilage will be having type 2 collagen. This was the AIMS question this year, right? So cartilage will be having type 2. Similarly, when we are talking about reticular tissue, right? So when we are talking about reticular tissue, then we will remember this mnemonic. Reticular is 3, right? So there will be 3. So this collagen will be type 3. So reticular tissue will be having type 3. Similarly, when examiner will ask you about the basement membrane, so how you will remember, basement membrane is like floor. Basement membrane is like a floor, and 4 is under the floor. That is how we will remembering, right? Basement membrane, 4 is under the floor. So these are the important points which we need to remember regarding collagen, right? So collagen, type 1 bone, type 2 cartilage, type 3 reticular tissue, type 4 basement membrane, right? Here what extra point we need to remember, that type 1 collagen will be present in skin also. This was the All India question. Skin will be having type 1 collagen, and skin will be having, or collagen 1 will be having maximum tensile strength in collagen. So maximum tensile strength of collagen will be present in type 1 collagen. So type 1 collagen will be having maximum tensile strength. That is another important MCQ of All India exam 2015. Maximum tensile strength is present in type 1 collagen, right? Another important thing which we need to remember, that even in a scar tissue you will be finding type 1 collagen, right? So scar tissue, that was the All India question in 2016. Scar tissue, type 1 collagen will be present. So these are the important MCQs which examiner had asked. AIMS exam, cartilage will be having type 2 collagen, right? AIMS exam, type 3 collagen is present in granulation tissue. This was the All India question also. So granulation tissue will be having type 3 collagen. So that was the question in All India exam. Granulation tissue will be having type 3 collagen, right? So granulation tissue will be having type 3 collagen. So this table is very, very important for our future exam also. So keep revising this table for future question also, right? See, so now I'm going to come back to the granulation tissue. As I started, granulation tissue is hallmark of wound healing. So how we are going to identify the granulation tissue, or you can say what are the components of the granulation tissue? What are the components of the granulation tissue? So granulation tissue consists of 3 things. Number 1, proliferating blood vessels. That is why they were looking pink in color. So proliferating blood vessels. Number 2, proliferating fibroblasts. So this is the number 2. And number 3, because these granulation tissue the blood vessel which will be new and proliferating, they will be leaky blood vessel, means endothelial gap will be more, and that is why they will allow any inflammatory cells to move outside. So what kind of inflammation you will see? Non-specific inflammation, right? So non-specific mononuclear inflammation. So they will be having non-specific mononuclear inflammation, mononuclear cell infiltrate, right? So these are the characteristic triad of the granulation tissue. So whenever we are talking about granulation tissue consists of three things, and that was the All India question in 2015. Okay, which is not a component of granulation tissue? Answer was granuloma. What are the other options? Proliferating blood vessel, proliferating fibroblast, and inflammation, right? So these are the three components of the granulation tissue. Now we are going to move to see how we are going to identify granulation tissue on histopathological specimen, and what is the importance of this granulation tissue. Whenever a surgeon will send a biopsy specimen or surgical specimen, that time pathologist is required to understand whether it is a healing wound or non-healing ulcer. Healing ulcer, non-healing ulcer. Because we know that healing ulcer, fine, we will give antibiotic. Non-healing ulcer, there are several causes. Infective, like TB or fungus, right? Malignancy, cancer, or any other immunodeficiency disorders, right? So that is why it is very important to identify granulation tissue on examination. So how we are going to identify? All three components we should be able to see on microscopic examination. So first we will know how to identify blood vessel. How to identify blood vessel? So first we should know blood vessel will be identified. Blood vessel will be identified when you will see that there is a lumen, and lumen is having RBC, right? So when a lumen is having RBC, it means we are looking at blood vessel, right? How you will identify proliferating blood vessel? That is important. So proliferating blood vessels will be having variable shapes and sizes of the blood vessel. Variable shapes and sizes of the blood vessel. So various shapes and sizes of the blood vessel. So some will be bigger, some will be smaller, some will be different shape like this, or some will be different shape. So now we can see variable shapes and sizes of the blood vessel. So variable shapes and sizes of the lumen containing RBC is a proliferating blood vessel. So this is how we are going to identify proliferating blood vessel, variable shapes and sizes of the lumen containing RBCs. How we are going to identify fibroblasts? So now challenge is for fibroblast. How you are going to identify fibroblasts? These are wavy fibers. So normal fibroblasts are wavy fibers which will be parallel to the skin surface. But when we have to identify proliferating fibroblast, how it will be? Proliferating fibroblast will be having haphazard arrangement, horizontal, vertical, tangential. So all will be having haphazard. So when they are having haphazard arrangement, then it is called as proliferating fibroblast, right? So variable shapes and sizes of the lumen containing RBCs, and then wavy fibers, proliferating fibroblasts will be there, which is disorganized, and mononuclear cells, you will see a nucleus, mononuclear cell, and there will be the cytoplasm small like this. This will be called as non-specific mononuclear inflammation. So that is how we will come to a conclusion that we are looking at the granulation tissue, right? So this is called granulation tissue. So this is how we will be seeing granulation tissue. And whenever you will see granulation tissue, examiner may ask this question, which type of collagen will be present in this granulation tissue? So always remember, granulation tissue will be having type 3 collagen, which was the question in All India and AIIMS both exams. So granulation tissue will be having type 3 collagen. This was the question, right? So just keep that in mind. Type 3 collagen will be present in granulation tissue, right? Now look at this picture, what I am going to show you. This is the perfect picture of the granulation tissue. In this diagram, what we are observing? If you take rule of 5, 1, 2, 3, 4, 5 and try to observe and compare, first thing you will notice there are certain lumen which is like this, where full RBC is packing them, and it is L shape. See, there is another blood vessel lumen different. So all these blood vessels, you see there are some smaller blood vessels also, right? Round oval, L shape, elongated. So variable shapes and sizes of the blood vessels. So what are these things? These are proliferating blood vessels. So these are proliferating blood vessels. Now again, when you will look at these 5 areas, you will notice how is the wavy fiber. Can you see how is the wavy fiber? Wavy fiber is having random arrangement. Look at this area which I am marking, right? So you can see in this area wavy fiber is having haphazard or random arrangement. So what are these things? These are proliferating fibroblasts. Proliferating fibroblast, and in between you can see scattered lymphocytes or scattered mononuclear cells. So these are scattered mononuclear cells. So this is the third thing, mononuclear cells. So when you find triad of these 3 things, this is called as granulation tissue, and whenever a pathologist will see it, he will come to a conclusion that this is the healing wound, right? Because granulation tissue is hallmark of wound healing, right? But the point is, when we are looking at the picture like this, fibroblast, this fibroblast can be a fungal infection also, right? So that time we have to be very careful. So whenever we are expecting some fungal infection, then we have to go for a special stain. So this is the special stain. We are seeing collagen is looking blue. So here I am showing you collagen is looking blue in color, and this special stain is Masson's trichome stain. This is Masson's trichome stain. So this Masson's trichome stain will identify collagen, and collagen will be blue in color, right? So when we suspect that this is collagen or fungus, then we will apply this Masson trichome stain, and on applying Masson trichome stain, we can see entire thing is appearing blue. So this is the collagen or fibroblast. So this will be confirming that we are looking at the healing wound or granulation tissue, right? So this is about granulation tissue. In repair, as I said, they will be having another step which is called as wound contraction, right? Which is called as wound contraction. So who is responsible for wound contraction? Now the question is, which cell is responsible for wound contraction? Because there is a loss of some tissue, and because of loss of some tissue, they will try to overcome the gap, and that gap overcome is done by a special type of cell called as myofibroblasts. Myofibroblasts. So myofibroblasts are responsible for wound contraction. So myofibroblasts are responsible for wound contraction. So what are these myofibroblasts? Myofibroblasts, one should understand, these are mesenchymal in origin. So these are mesenchymal in origin. That was the question in older All India exam. So myofibroblast is responsible for wound contraction. This itself is an older question. They are mesenchymal origin, and when you will see them ultrastructurally, so what are these ultrastructural things? These ultrastructural thing which we are seeing, ultrastructural means on electron microscopy. So on electron microscopy, myofibroblasts are the fibroblasts. So these are the special type of fibroblasts. On electron microscopy, there are a special type of fibroblast which will be having a smooth muscle like contractile activity. So smooth muscle like contractile activity is there. That is why they are called as myo. Right? Can you see this name? Myo. Myo means muscle. So muscle like contractile property is present in this fibroblast. That is why it is called as myofibroblast. Right? So this myofibroblast is responsible for wound contraction. Right? So in this wound contraction, when we are seeing what happens in this wound healing when we are having wound contraction, right? What happens in this wound healing when there is a wound contraction going on? So this is because of collagen change, or you can say tissue remodeling. So this wound contraction is because of tissue remodeling. Wound contraction is because of tissue remodeling. What happens in tissue remodeling? Or what is tissue remodeling? The basic question is, what is tissue remodeling? So tissue remodeling is conversion of granulation tissue to scar formation. Granulation tissue to scar formation is called as tissue remodeling. That's all. Granulation tissues to scar formation is called as tissue remodeling. What happens in this? As we all know that granulation tissue is having which collagen? Type 3 collagen, right? So this type 3 collagen will be having degradation, and after degradation, scar tissue will be having only one type of collagen, that is type 1 collagen. So scar will be having type 1 collagen. So collagen 3 degradation and collagen 1 synthesis is called as tissue remodeling. So who is doing this tissue remodeling? Which enzyme is responsible for this tissue remodeling? So this tissue remodeling is done by matrix metalloproteinase. So there is an enzyme called matrix metalloproteinase. Right? So matrix metalloproteinase is responsible for tissue degradation or tissue remodeling. So matrix metalloproteinase will be converting or degrading type 3 collagen and synthesizing type 1 collagen, and that is the responsible thing for the tissue remodeling. So matrix metalloproteinase, for their function, this is one important MCQ, for their function, which element is most important cofactor? So remember, zinc is most important cofactor for the functioning of matrix metalloproteases, right? So that is the important MCQ which had been asked in exam. Okay, what is the most important? So remember, zinc is most important. Remember, zinc is most important cofactor for function of matrix metalloproteinase. And what is function of matrix metalloproteinase? To degrade collagen 3 of the granulation tissue and to synthesize type 1 collagen in scar formation, right? So this is called tissue remodeling. So this is how wound healing, you will be seeing a scar formation, and this scar will be having contractility because of the presence of myofibroblast, right? So now we have seen about repair. In this repair, we have seen two things, if you remember, granulation tissue formation and wound contraction and scar formation, right? Now next thing we are going to discuss is cutaneous wound healing. So now next topic we are going to see is cutaneous wound healing. In cutaneous wound healing, we can divide them into two categories: primary cutaneous wound healing or secondary cutaneous wound healing. We can divide this cutaneous wound healing into primary cutaneous wound healing or secondary cutaneous wound healing. Primary or secondary cutaneous wound healing. Primary or secondary. So what is the difference between primary and secondary cutaneous wound healing? Take one example of surgical incision. So when surgeon is performing surgery, he will apply surgical incision. When you will see the surgical incision healing, they will be healing with clean opposed edges, right? So when there is a wound healing is with clean opposed edges, right? So clean opposed edges, and there will be no gap, right? So opposed edges means there will be no gap. That is the catch point. So remember, when there is a wound healing with clean and opposed edges, right, as you see in surgical incision. So these are the important MCQs, right? Surgical incision will be having which type of healing? Primary wound healing. What is the primary wound healing? When wound is healing with clear cut opposed margins and there is no gap between them, that is called primary wound healing. Secondary wound healing will be seen in those areas where you will be seeing injury or trauma is causing loss of tissue. So when there is a injury causing loss of tissue, so in this case wound healing is with gap formation, right? So wound healing is with gap formation. So when there is a gap formation in wound healing, this will be called as secondary wound healing, right? So there will be gap between wounds, so that will be called as secondary wound healing. And secondary wound healing, because of there is a gap, see, suppose I am showing you, this is the area of skin where damage was done, and this area, this amount of tissue has been lost, right? So during wound healing, what will happen? There will be presence of myofibroblast at the margin. See, at the margins I am showing you myofibroblast. So this myofibroblast will start contracting, right? They will start contracting. So we will see wound contraction. So what I want to say that wound contraction will be more prominent in this condition, because when you will see the primary wound healing, as you can see in surgical incision, see, there is a minimum wound contraction, but here wound contraction will be prominent. So examiner had asked this question in exam: prominent wound contraction is seen in. So prominent wound contraction will be present in secondary wound healing. Prominent wound contraction will be present in secondary wound healing. So that is one important MCQ. Already we have seen the wound contraction is because of myofibroblast, right? Mesenchymal, and ultrastructurally it is the fibroblast, right? With the smooth muscle contractile activity. So prominent wound contraction will be seen in the secondary wound healing, right? So now we will see what are the day-wise changes in any cutaneous wound healing. So what I'm going to say that changes in wound healing, day-wise changes in cutaneous wound healing. That is very important topic for exam, right? Day-wise changes in cutaneous wound healing, day 1. That is very, very important. What are the changes you will see on day 1? What is the earliest cell to appear on day 1? This was the JIPMER question in 2014, and it's a tricky question. Question was, what is the earliest cell? What is the earliest cell to appear? Earliest cell appearing day 1, right? So what is the earliest cell appearing on day 1? Neutrophil or platelet? So many students have given answer as a neutrophil, but remember, whenever there is a cutaneous injury, what will happen first? There will be leakage of the blood, and fibrin and platelet will be coming to form the hemostatic plug, right? So always keep that in mind. Whenever earliest cell appear, which cell appear first, or earliest cell to appear first, your answer must be platelets. Platelets are coming earlier than neutrophil, right? So this is one language. Now look at the another language which examiner can ask in future exam, or which examiner had asked in All India exam earlier also. Which cell will appear first by chemotaxis? Which cell will appear first by chemotaxis? So which cell will appear first by chemotaxis? See, the language has been changed. Which cell will appear first on day 1? Platelet. Which cell will appear first on day 1 by chemotaxis? See, the word chemotaxis is the catch point, because platelets, they do not have chemotaxis in human body, right? Platelets do not follow chemotaxis in human body. So who will be responsible for chemotaxis? So this chemotaxis will be bringing up neutrophil. So first cell to appear in peripheral blood by chemotaxis, answer should be neutrophil, and that is the All India question. Neutrophil will appear first, right? Now I wanted to tell you one important thing. What is the lifespan of the neutrophil? Question is, what is the lifespan? What is the lifespan of neutrophil? Right? Another important and frequently asked question in exam, especially in peripheral blood. So when we are talking about peripheral blood, this was the All India question. Peripheral blood, lifespan of neutrophil is 6 hours, and that was the answer. So lifespan of neutrophil in peripheral blood is 6 hours, right? So maybe a future question can be asked in your exam, okay, what about tissue? So what is the lifespan of neutrophil? In peripheral blood, it is 6 hours, but when it is about tissue, it will be for 1 to 4 days, right? It should be 1 to 4 days. What will be the lifespan of platelet? That was the question in All India 2016, right? Platelet Platelet lifespan, just remember this point, 7 to 10 days. Platelet lifespan is 7 to 10 days. And that was the question in All India exam 2016. Platelets lifespan is 7 to 10 days. Neutrophil lifespan in peripheral blood 6 hours. In tissue it is 1 to 4 days, right? So day 1, it is first cell to appear is platelet. First cell to appear by chemotaxis is neutrophil. Survival of neutrophil will be 6 hours in peripheral blood and tissue is 1 to 4 days. So approximately on day 3, when you will see day 3 wound healing, when you will look at day 3 wound healing, what you will observe? On day 3, neutrophil will be replaced by, remember, neutrophil will be replaced by macrophages, right? So neutrophil will be replaced by macrophages, so that is important, right? So day 3 neutrophil will be replaced by macrophages and early granulation tissue will start forming on day 3. Early granulation tissue. So early granulation tissue will be formed on day 3, another important MCQ which examiner asks in exam, right? Day 5. What you will notice on day 5? Day 5, you will be finding maximum granulation tissue. So granulation tissue will become maximum, right? And another important feature, you will notice on day 5, epidermal thickness will be recovered, right? So here you can see epidermal thickness will be recovered completely. So that was the question in AIMS 2015. Epidermal thickness is recovered. So epidermal thickness is recovered completely on day 5, right? So epidermal thickness is recovered. How you will understand that epidermal thickness is recovered? How examiner can ask future question? Future question can be asked कि maximum proliferating blood vessels and fibroblasts are seen and stratum corneum is visible. Stratum corneum, uppermost layer of the skin. So whenever examiner says stratum corneum, means epidermal thickness has been recovered. So just remember this point. How you will understand that it has been recovered? You will be seeing stratum corneum. So when examiner says stratum corneum is seen on which day? Answer should be day 5, means epidermal thickness has been recovered. Day 14. Day 14, you will see maximum collagen deposition. All India 2015, this was the question. Maximum collagen deposition is seen on which day? So maximum collagen deposition is present on day 14, right? And scarring will be completed by day 28. So that is also one important thing which we have to keep in mind, right? On day 28 means approximately 1 month. So 1 month time will be taken by cutaneous wound healing for scarring or completion of scarring. So scarring is completed. Scarring is completed in case of cutaneous wound healing, right? So this is very important, day wise changes in cutaneous wound healing. Here I would like to tell you some salient features, or you can see comparison or for understanding. When we are talking about cutaneous wound healing and comparing them versus myocardial infarction wound healing, right? So myocardial infarction wound healing and cutaneous wound healing, and examiner says one statement. Just imagine if examiner says कि cutaneous wound healing will be delayed in comparison to myocardial infarction wound healing. Will it be a true statement or a false statement? Right? So now we have to understand this one, right? Okay, actually this is the false statement. Cutaneous wound healing will be always having shorter time. Myocardial infarction wound healing will be having longer time. Just example I am giving you. Suppose I get a cut here, right? By cutaneous wound healing will be there and it will be over by 1 month or 2 months. So it will be completely healed, right? So by the end of first month, cutaneous wound healing will be done. But when somebody says that you cannot become a good surgeon or you cannot become a good clinician, take my word, but you wanted to prove it and you have prepared for your exam and after few years you became a biggest clinician or one of the famous clinician. So that is called healing of the heart, right? So healing of the heart. So always remember, healing of the heart will be always delayed. So this point we have to remember, this will be delayed in comparison to the cutaneous wound healing. Cutaneous wound healing will be earlier, and myocardial infarction wound healing will be always delayed. For example, why I wanted to discuss like this, because examiner asked question ki early granulation tissue, this was the All India as well as JIPMER question. Earliest formation of the granulation tissue, if you remember cutaneous wound healing, we have read ki it will be approximately day 3, right? But in case of myocardial infarction wound healing, it will be from day 7 to day 10, and that was the question, right? So this was the question in JIPMER and All India exam. Myocardial infarction wound healing, early granulation tissue formation is present on which day? Early granulation tissue formation will be 7 to 10 days. So that was the question in JIPMER exam. Same way, the older question is maximum granulation tissue. Maximum granulation tissue will be present on day 5 in case of cutaneous wound healing, whereas it will be day 10 to day 14 in case of myocardial infarction. Another important MCQ in exam, day 10 to day 14 will be having maximum collagen tissue, right? Another maximum granulation tissue in myocardial infarction wound healing. And same way, scarring will be completed. Scarring will be completed. If you remember, it was 28 days, which I wrote 1 month, right? Whereas in case of myocardial infarction, it will be 2 months. Another important All India question, right? So it will be taking 2 months for myocardial infarction. So now we can understand when we are talking about cutaneous wound healing, right? Cutaneous wound healing, we can see it will be earlier in case of cutaneous wound healing. When we are talking about myocardial infarction wound healing, it will be delayed. And these are the comparison, right? Now we will see strength of wound healing, or you can say strength of wound. So how you will measure, or how you will expect wound strength? So what will be the strength of any wound, or what will be the deciding factor? So most important factor to decide strength of a wound or tensile strength of the wound is the collagen deposition, right? So tensile strength of the wound is directly proportional to the collagen deposition. Collagen deposition, or you can say cross-linking of collagen, or you can say cross-linking of collagen. So cross-linking of collagen is one of the most important factor for tensile strength of the wound, right? So remember, this is the most important factor for strength of wound. So cross-linking of collagen will require which vitamin? That is another important MCQ which examiner had asked in AIIMS exam, right? And All India exam also. So for this, we need to understand that vitamin C is the most important, right? Because vitamin C will do hydroxylation of, vitamin C will perform hydroxylation of lysine and proline. So these amino acid, lysine and proline, hydroxylation, why it is required? So vitamin C, which is causing hydroxylation of lysine and proline, this step will convert tropocollagen to collagen. So this is how cross-linking will be done. So tropocollagen will be having impact of lysine and proline, and then it will be converted into collagen, and this is how strength of wound will be increased. So that is why I wanted to tell you this cross-linking of collagen is the most important factor, and for cross-linking of collagen, most important vitamin is the vitamin C by causing hydroxylation of lysine and proline. So this is how cross-linking will be done. Wound strength will be achieved. Wound strength will start increasing. So here we need to understand some more important MCQ. Wound strength will start increasing by day 5 to day 7. So approximately you can see at the end of first week, wound strength will start increasing, and this will be 10% of the original strength. So this will be 10% of the original strength, right? So whenever examiner says after any injury, wound healing or wound strength will be start increasing by what day? So your answer should be 5 to 7 days, right? Answer should be 5 to 7 days, and that will be 10% of the original strength. Second thing which examiner can ask you, so when they will have 100% strength, 100% strength of original wound, right? So 100% strength is never achieved. Remember this point also. 100% is never achieved in wound healing. So what is the maximum limit? What is the maximum limit of wound strength? So here we need to understand maximum strength will be 70 to 80% of original. 70 to 80% of original. So maximum strength attained by any wound is the 70 to 80% of original, and this will be achieved by the end of, remember another very frequently MCQ, a very frequently asked question. This is the very frequently asked question. Maximum strength is 70 to 80% and it will be achieved by the end of third month. By the end of third month, right? So that is the important point we have to remember. By the end of third month, maximum strength will be achieved, which is 70 to 80% of the wound strength, right? So this is how we can understand wound strength. Here, I would like to tell you one important question, which was the PGI question, little conceptual question, right? Question was, fetal cutaneous wound healing strength is, So I am going to tell you one important conceptual question which was asked in PGI exam. Fetal cutaneous wound healing, you will see scarring or no scarring. So that was the statement given in PGI exam, and we should understand in fetal cutaneous wound healing, in fetal cutaneous wound healing, there will be no scarring. So there will be no scarring in fetal cutaneous wound healing. No scarring. Why there is no scarring? Now this is the important thing, right? So answer was right. So that statement was right, there is no scarring. But why there is no scarring? That can be the future question in All India or AIMS exam, right? Why there is no scarring? So now we are going to see that. Why there is no scarring? Because there is no expression of osteopontin gene. No expression of osteopontin gene. So osteopontin gene is required for fibrosis, and this is not expressed in fetuses. So this is number one reason. No expression of osteopontin gene. So just keep that in mind, can be a future question, right? So this could be a future question. No osteopontin gene expression, and there is non-fibrogenic transforming growth factor beta, which is present in fetuses. So fetuses will be having non-fibrogenic, because fibrosis in cutaneous wound healing is basically because of the TGF beta, right? But in fetal cutaneous wound healing, there will be, fetuses will be having non-fibrogenic variant of the transforming growth factor beta. So that is why there will be no cutaneous wound healing, because of the no cutaneous wound healing with scarring, right? So there will be no scarring because of lack of fibrogenic cytokine. Third important and most conceptual part of this discussion is lack of involvement of CD4-TH2 cells, right? So this is the lack of involvement of CD4-TH2 cells. So now the question comes to our mind, how these CD4-TH2 cells are associated with fibrosis? How? So now it is very, very important to understand how TH2 cells are associated with fibrosis. To understand this concept, I will explain you one of the important thing regarding macrophage, which examiner had asked in this year All India and DNB exam, right? Macrophage, we all know that the development of macrophage, they arise from the monocytes, right? Monocytes will be forming macrophages, and macrophages are activated. They are called as activated macrophages. So activated macrophages, this is the important concept which we have to understand. Activated macrophages are of two categories: classically activated macrophages, alternatively activated macrophages, right? So these are two categories of the macrophages. These are the two categories of the macrophages. One is called as classically activated macrophages, right? So classically activated macrophages are also known as M1, right? So this is the classically activated macrophages, M1, and second is alternatively activated macrophages. Second is alternatively activated macrophages, which is also called as M2. So these are two groups of the macrophages. Classical is M1 and alternatively is M2 macrophages, and these two macrophages will be having different functions. So we will talk about them because examiner had asked question from this M1 macrophage. So we have to keep that in mind. M2 can be a future question, right? So M1 macrophage, when we see who will be activating, so activation is done by which cytokine? Activation is done by interferon gamma, right? So classically activated macrophage, their activation is done by interferon gamma, and once they are activated, what they are going to release or secrete? So secretion will be consisting of interleukin 2, interleukin 12, right? So what will be function of this classically activated macrophage? Function. So their main function is killing of the microbes. So microbial killing, right? So classically activated macrophages are responsible for microbial killing and associated with pathological inflammations, right? So they are associated with pathological inflammation. So these are the two important things we have to remember. Microbial killing, pathological inflammation is associated with classically activated macrophage, which is M1, right? And when we talk about alternatively activated macrophage, that is important. So who is going to activate alternatively activated macrophages? So activation is by a cell which is called as CD4-TH2 cells. So that is the important concept we have to understand. CD4-TH2 cells, how they are going to activate alternatively activated macrophage? The CD4-TH2 cells, they will be releasing cytokine, which is the interleukin 4, 5, 6, right? So TH2 cells, they release cytokine IL-4, 5 and 6, and these IL-4, 5 and 6, now they are going to activate this alternatively activated macrophages. So this will be activating alternatively activated macrophage. So this we can understand, okay, that is what I wanted to correlate here. Okay, CD4-TH2 cells, they are going to release IL-4, 5, 6, which will be activating M2 cells or alternatively activated macrophages. And once this alternatively activated macrophages are activated, what they are going to release? So what will be the secretions? What will be the secretions from M2? So alternatively activated macrophages will be releasing cytokines called interleukin 10 and transforming growth factor beta. So now you can see that IL-10 and TGF beta, right? IL-10 and TGF beta. Do you remember when we were discussing about cytokine? That time I told you TGF beta, IL-10, these are anti-inflammatory cytokine, right? Anti-inflammatory cytokine helps in autoimmune disorders to suppress autoimmunity and helps in wound healing and repair. Wound healing, how? By fibrosis. So IL-10 and TGF beta, when they are present, so now you can understand easily what will be the function of alternatively activated macrophages. Number one is wound healing and fibrosis, right? So it is wound healing and repair. So wound healing and repair, right? And as we all know that these are anti-inflammatory cytokine, so they will prevent autoimmunity, right? So this will be the second important function. They will prevent autoimmunity. So they will prevent autoimmunity because they will inhibit proliferation and differentiation of autoreactive cells. So that is why these are anti-inflammatory. We can say that M2 macrophages are anti-inflammatory, M1 macrophages are inflammatory. So now coming back to that question where we were discussing why there is no fibrosis in fetuses, because of the lack of Th2 cells expression, right? So now you can see that why I said like this. Th2 cells are responsible for activation of M2 macrophage, and M2 macrophage will be releasing cytokine TGF beta, which will cause fibrosis. So there is no Th2, no M2 activation, and no TGF beta formation, no fibrosis, no scarring. So that is the important concept we have to keep in mind, right? So when we were talking about scar tissue, as I have told you, scar tissue formation is a part of tissue remodeling. So this scar tissue can be abnormal also, right? So scar tissue can be abnormal also. So this scar tissue can be hypertrophic scar. Scar tissue can be hypertrophic scar, or it can be keloid. So these are two types of abnormal scarring, right? Keloid formation and hypertrophic formation, right? So how we are going to differentiate these two, hypertrophic scar versus keloid scar, is very important to understand, right? What is the hypertrophic scar? Characteristic property of hypertrophic scar. Suppose this is the original wound. Suppose I am showing you this is the original wound area, and scarring will be limited to the original wound area only. That is the definition of hypertrophic scar. So when you see scarring, is limited up to original wound, right? So scarring is limited up to original wound. This is called as hypertrophic scar, right? So scarring is limited to the original wound area. This is called as hypertrophic scar, right? What is keloid? So again I am showing you, suppose this is the original wound, right? So this is the original wound, and when you see the scar and a scar is beyond the original wound area, this is called as keloid, right? So what I'm describing here, scar tissue is beyond the boundaries of original wound, right? So beyond the boundaries of original wound. So scar tissue is beyond the boundaries of original wound, So that is called as keloid. So that is how we can see the differentiation between the hypertrophic scar and keloid. Hypertrophic scar is limited to the original wound area, and keloid is beyond the area of original wound. So another important difference, you will notice that hypertrophic scar, they can or they may resolve spontaneously, or they may regress spontaneously. We can say they may regress spontaneously. But in case of keloid, there will be no spontaneous regression. There is no spontaneous regression. So they will be having multiple recurrences, right? So no spontaneous regression will be seen in case of keloid, right? Another important difference, keloid versus hypertrophic scar, when you will see, hypertrophic scar is having no genetic association. So here we have to understand there will be no genetic association, whereas you will find they are having genetic association. And they are commonly seen in African origin, right? African origin. And most common site for them, you will see most common site. Hypertrophic scar, there is no most common site, but most common site for keloid will be sternum, right? So most common site for keloid scar will be sternum. So that is another important MCQ which examiner asks. Sternum is the most common site for keloid development. When we see the morphology, means microscopic examination. So I am just showing you, this is the skin biopsy. These are the two biopsy I am going to demonstrate here. and this is the epidermis. This is the epidermis. So when you are going to see the collagen bundles, how you will notice this collagen bundles? Collagen bundles, when you will see, they will be very thin. They will be thin and they will be parallel to the, their orientation will be parallel to the skin surface, right? So collagen is thin, parallel to the skin surface. That is the very important thing to understand. Thin collagen, right? So thin collagen, and their orientation will be parallel to the skin, parallel to the skin surface, right? So this is how we will identify hypertrophic scar. In hypertrophic scar, collagen will be thin and they will be having parallel arrangement to the skin surface, as I have demonstrated in this diagrammatic picture. So in keloid, you will see wavy fibers, and these wavy fibers means this collagen, they will be having thicker collagen bands. So you will find thick collagen bands here. You will see thick collagen bands and they will be having disorganized, right? They will be having disorganized arrangement. So you can see they are disorganized, dense or thick collagen band, right? So disorganized, dense and thick collagen band will be seen in keloid scar, right? So keloid will be dense collagen. You can see they are haphazard. Some will be horizontal, some will be vertical, like that, right? So horizontal, disorganized, dense, thick collagen will be present in the keloid. So that is the differentiating feature which I am going to show you on microscopic examination also. See, this is the picture which examiner can ask in exam, right? When you are looking at this picture, you can easily make it out that this area is limited to the original wound. So this is the hypertrophic scar. This is the hypertrophic scar. But when you observe microscopy of this area, now you can see in this area, there are so many eosinophilic collagen bands. You can see these are all wavy collagen bands. So these are all thin collagen bands. So wavy fibroblasts are arranged parallel to the skin surface. So this is the hypertrophic scar. How we will say that these are the collagen band only? How we will say that these are the collagen band? By performing a Masson trichome stain. So we perform Masson trichome stain. Now you can see blue collagen. So Masson trichome stain, collagen will be blue. Keep that in mind, can be your future question. Masson trichome stain, collagen will be blue. So we can see this collagen is blue in color, right? Hypertrophic scar. Now look at this earlobe. You can see this earlobe is having very big scar. So this is the keloid, right? This is the keloid. Microscopic examination, very beautiful picture. You can easily appreciate, see how are the collagen band. They are more eosinophilic and they are dense, and you can see how is the arrangement of the collagen band. They are all haphazard. So haphazard, dense, thick collagen band will be suggestive of keloid. So this is the keloid microscopic examination, and how you will confirm? You are going to confirm this by Masson trichome stain. So you can see Masson trichome stain, collagen is blue and very thick in comparison to the upper thin collagen. So this is the Masson trichome stain for the keloid scar, right? So this is all about inflammation chapter. Now we will see next chapter of genetics.